Oh yeah, I remember this one. So when putting together this talk, I will show you what comes new from our research group in 2018. This is not a comprehensive overview about what other groups have done or what other groups focus on, like Rohit Shetty's group. This is more or less what we have been doing in the past 24 months or 3 years. Let's start with oxygen. It's very simple to understand how oxygen works, and once you have understood the concept, you will understand why certain newer techniques fail to work properly. These are the only 2 sentences you need to digest. First of all, oxygen limits the increase in biomechanics, and you cannot circumvent photochemistry. You cannot circumvent nature. Now let's look at this in a closer way. This is textbook knowledge. First of all, 1972, IOVS, the epithelium eats a lot of oxygen, 10 times more than the stroma. So 50 microns of epithelium use as much oxygen as 500 microns of stroma. Keep this in mind. And the second one is, if you switch on UV light here, then the oxygen saturation drops very rapidly to very low levels. And then once you switch the UV light off again, it needs quite some time to rediffuse. And that's also physiology. It is depleted within seconds, and it needs minutes to come up again. Now, these 2 factors put together will explain why many of the newer techniques do not work that reliably, and we have published on all of them, both on the basic research and on the clinical side. It explains why accelerated, epi-on, pulsed, and even iontophoresis epi-on cross-linking have their downfalls. Looking at accelerated, for example, and I very much appreciate the talk of the colleague that was given 2 or 3 talks before this one, who was reporting that accelerated cross-linking does not work reliably, and that they currently stick to 9 milliwatts for 10 minutes. Let me show you something here in the upper left. We published this in 2014 in ex vivo, showing that the Dresden protocol, which is the blue column, works best in terms of biomechanics, and the red one is 9 milliwatts for 10 minutes. So the red one here already is substantially, significantly worse biomechanically than the Dresden protocol, but it might still be enough in clinical practice. And this is why until now in adults I've been sticking to 10 minutes, 9 milliwatts. I use the Dresden protocol in children because I want to have the strongest effect. But just a few days ago I accepted to review a paper that is under submission now, very solid method section, a prospective randomized clinical trial clearly showing that with a 2-year follow-up, the 10-minute protocol is not as good as the Dresden protocol. So I believe I will go back to the Dresden protocol for all my patients. That is very annoying regarding the time I spent in the operating theater, but it will give the best outcome. And also the others. If you look at the upper right, this is epi-on. I will speak a little bit more about epi-on later. If you have an epithelium that blocks oxygen diffusion, you can do whatever you want to get your riboflavin in there. You can partially destroy it, the epithelium, and still call it epi-on and put a bandage lens on it. You can use iontophoresis to push your riboflavin in. You still have the oxygen barrier. And this is why epi-on does not work reliably, at least in our hands and in the hands of most surgeons on a global level. We'll speak about an exception later. Pulsed cross-linking is not something I use in daily practice simply because I showed you the textbook physiology from 1972, seconds to be used and minutes to replenish. So any protocol that gives us a 1 second on, 1 second off blinking cannot be more efficient than continuous light. And indeed, we showed this both here experimentally and together with the Persian group in clinics, that there is no advantage over continuous light. So this is as much as oxygen goes. And there's yet another factor that I have not put on this slideshow because the results are so new. We have identified oxygen. Another group around Theo Seiler and his son have looked at hydration of the cornea, which seems to be yet another factor that intermingles with results. And we have identified just very recently a third factor, which seems to be temperature. There is recent data showing that if you reduce the temperature of a tissue, the oxygen diffusion increases. So we thought, okay, let's test. Let's perform stress-strain measurements ex vivo in chilled corneas. And the results were substantially better. We will look more into it. And if this really is reproducible, then we might want to chill our corneas just the way we chill after PRK. But in the case of cross-linking, we might want to chill our corneas before irradiation. As I said, this is brand new, but based on a quite solid number of samples, and we see distinct differences in the biomechanical response, a massive increase if we cool down the corneas. Now I'm stuck for some reason. AV doesn't go forward. Yes, let's see. Now it's going back. That's interesting. No, that was not. That's magic. Let's try to find an overview. Okay, let's just continue here. Mechanics is something we are working on currently. We are working on a model that will give us more insights into mechanics. So this is just a placeholder slide that draws your attention to the importance of mechanics. We will have a debate with Damien Gatinet later on. I do not believe that this is the all-for-one solution and answer, but I think it might be an interesting trigger. Another element, maybe you try to just give me the overview, just the 6 slides, because apparently there is an issue. Another element that is important are hormones. We all know now for years that estrogen is a major player. Here we are. Let's see. Let's just jump through it. Maybe it'll be with us. No, it does something else again. Hormones. We know about estrogen. There is yet another factor. How many of you screen for thyroid hormone changes in your ectasia patients? Well, you should. Thyroid hormone seems to be a major modulator. There is a number of hints. On one hand, we know since the 1930s, 40s that whenever you look at hypothyroidism, the incidence of keratoconus is increased by a factor 10. If you remove the thyroid for whatever reason, the risk for keratoconus increases by a factor 12. We have published a paper in the American Journal in a prospective study on pregnant women and looking at the topographies, and we have seen that all changes in topography were not related to estrogen increase, but to hypothyroidism during pregnancy. And we just published 2 more case reports back to back in the April issue of the Journal of Refractive Surgery, pointing to the importance of the thyroid. So TSH, T3, T4 seem to correlate even more with exacerbation than estrogen. Case of a 53-year-old lady that never has had any signs of ectasia. Then she has the thyroid removed, and 12 months later, she has bilateral keratoconus. Another aspect is Individualization, and that's number 2. I will not even try to press the button. But we have spoken about thin corneas a lot in the last years. What do you do with the cornea that is thinner than 400? Well, we all know about swelling of the cornea. That's the technique that we established in Zurich back in 2007. And then there were many other techniques that tried to deal with thin corneas. A famous one comes from India with Susan Jacobs. Contact lens assisted cross-linking. They all share one thing. They modify thickness. We, by swelling the cornea, modify thickness. Susan modifies the thickness by including a contact lens. Well, this is yet another factor that makes the procedure sometimes a little tricky, because you have a speculum that promotes evaporation of the stroma and thinning. You have riboflavin instillation that can vary thickness depending on how often you instill. Then you have a contact lens. What is the oxygen diffusion coefficient? Or in the case of swelling, not every cornea swells the same. In short, this is sometimes a protocol that is difficult to handle for a beginner. It would make so much more sense not to vary thickness, but to vary the overall energy you use in every single patient. In other words, in a 400 micron cornea, you use 5.4. So if you do an epi-off, instill riboflavin for 20 minutes, and you end up with 295 microns, why can't we adapt the fluence to that particular thickness? We couldn't do this 10 years ago because we did not know enough about riboflavin diffusion, about oxygen at all. But now we can. And our group published the algorithm back in 2016 in the JRS, and we've been now doing this in almost 60 eyes with a follow-up of more than 1 year. And we individualize fluence for every single cross-linking patient. This is not customized cross-linking with different zones. It's individualizing the overall energy in every case according to thickness. And the thinnest we have treated was 245 microns. And we limit the upper limit to 395 because afterwards you can just use the standard protocol. And this is quite promising. We have a demarcation line that in almost all cases stops 60 to 70 microns above the endothelium. The question, of course, is, can we stabilize such a thin cornea with such a protocol? But this we will see in long-term results. The beauty of this technique is that you can have a highly standardized approach, and this is what we all dream about. I don't want to be thinking about every single patient and how to install the drops and take out the speculum, yes or no. I want to also tell my junior colleagues, always use the same protocol. In the end, measure thickness, look into this table with the algorithm, choose the appropriate fluence, and go with it. I think this will be the future of cross-linking besides customization. Regarding infection, so PAC cross-linking, there have been 2 recent developments from our group. We have published a small monocentric prospective study of 27 eyes together with Boris Kneiser from Israel. And we have used highly accelerated cross-linking, so 30 milliwatts for 3 minutes. And the results were just as good as the Dresden protocol. And we have unpublished lab data that indeed show that this Bunsen-Roscoe law of reciprocity that gives us such a headache in keratoconus treatment, it does not give us a headache in infection. It is apparently independent of oxygen supply. So we can kill at very high speed with the same overall fluence of 5.4. This is what we have just published clinically in Cornea in January. And we are about to submit a paper that in the lab goes up with fluence to 7.2, and at 7.2 joule we have a much better bacterial killing rate. So what we are doing right now is still trying to find the best clinical settings to be as efficient as possible. Mechanics, I have mentioned mechanics, and the last one is fact versus fiction, and this is a problem that has been with us since day one of cross-linking. Some of the results you hear, I doubt. Some of the results I have a very hard time understanding, with a special regard to epi-on. And as my colleague before has mentioned, there seem to be some groups in the US that claim to have found the holy grail of epi-on cross-linking. We have discussed this in length at the last cross-linking Congress. Rajesh, you were there. And we have published a statement in a trade journal because we wanted to have maximal outreach to the general ophthalmologist who might not always read IOVS in the evening. And we have published a statement in The Ophthalmologist, Theo Seiler, Paolo Vinciguerra, Brad Wendelman, and myself, telling this large group in the US that promotes epi-on, show us your hand. Because our main issue is that all the data that have been shown on epi-on does not tell you about the inclusion criteria of the study that was performed, and the inclusion was any keratoconus of any age, no progression documented. And if you don't document progression and you have a stable cone, you perform epi-on and then show stable results, well, bravo, that's really highly interesting. And this is the level on which we have to dispute sometimes. And so we had to give a very clear and bold statement in the Ophthalmologist's February issue, if you want to read it. So this is the circle we are working on right now. I think the most interesting one for me, as per now, for my clinics is thyroid. So I have thyroid hormone level tested in all my patients, and we see quite a few interesting changes in patients with hypothyroidism. It can also be a nice means for you to connect with your local GPs and endocrinologists. Just let them know if the family doctors and GPs around you face patients with visual changes during pregnancy. This, and even the opticians and optometrists, this might not only be the normal shift due to estrogen, it might be physiological hypothyroidism, or in case of endocrinology, just let them know any patient with hypothyroidism should get a screening in the case of complaints of visual symptoms. So just a nice way to bond with your local network. Next year, or in 2 years, or whenever, I will try to get this crazy presentation work. Thank you very much.
Thank you, sir. Sorry for not working of that presentation. I would like to have any comments from the audience, as he has put so many new concepts in front of us. So, anything?
Absolutely, yeah, because the number is so low that this should be very easily feasible, yeah. Interestingly, there is a physiological dip, this is how we found it, a physiological dip of thyroid hormone in 4 or 5% of all pregnant women. And in our study, even if we eliminated the few women that had this dip, we still saw relevant changes, yeah, related to thyroid hormone.
PCOS, we have seen patients, I think we have seen even in patients with PCOS, polycystic ovarian syndrome, patients develop ectasia.
Patients with, sorry, which syndrome?
Polycystic ovarian syndrome.
Mm-hmm.
Yeah.
This would then produce more estrogen, right?
I think it's less estrogen.
Less estrogen. Yeah. Okay, interesting.
More estrogen.
More
estrogen. More estrogen, is it?
More, right? That's less surprising. Okay.
Dr. Hafezi, this limit of 400 microns was set about basically because we didn't want any damage to the endothelium.
I'm sorry, it's almost impossible to hear there.
I said we can as well sit and talk here. When I said this limit of 400 microns for taking up patients for CXL was set about because of damage to endothelium, concerns about, but then there's almost double the safety margin that's allowed. Now that our machines are much more precise, even without calculating, do you think we can drop down this 400 microns to say 350 or 360? Because we know even with that level of fluence, there's not enough amount of fluence reaching the endothelium to damage it.
You're absolutely right. First of all, the 400s with the Dresden protocol, in fact, are 330. So 70 microns were already 15 years ago included as a safety margin. And the other issue is that, yes, the overall threshold level for the endothelium is probably much higher. Otherwise, our vitro could not do 7 and even 15 joule per square centimeter over certain regions of the cornea. So we need to adapt the overall fluence in the future for the threshold level, and then again individualize, as I showed you. I think that would be...
At the present level of knowledge, would you like to revise that 400 microns and give us some other number which we could consider as a cutoff?
I would follow Rajesh's talk on science and noise, because I first want to validate these numbers. What we see now is if I use the algorithm the way we have established it now, we run into trouble at roughly 300 microns, because probably the overall fluence is just not high enough. So we have to learn now to adapt this algorithm over the next 1 or 2 years, and then we will have a table that clearly shows you how much is the maximum for which, but it'll take some more time.
It was a very interesting presentation, thank you.
Thank you.
Just wanted to know, when you were trying to individualize the fluence, is it also the time that you can modify, or it's just the fluence that you should be modifying?
There is always a confusion about the term fluence. Fluence is the product of intensity times time. So the intensity may be 3 milliwatts, the time is 30 minutes. In seconds, this is 1,800 seconds. 1,800 seconds times 3 is 5,400 millijoule. That's the fluence. So you can modify the fluence either with time or with intensity. We decided to keep the intensity at 3 milliwatts for this study, because anybody in this world at least has a 3 milliwatt machine, and then we dropped the time. So for example, for 280 microns, I'll just give you a random number. We know that we use a 3 milliwatt lamp for 7 minutes, 55 seconds. And it gives you a demarcation line close to the endothelium.
And what are your views about linking along with a CXL?
You mean a topography guided PRK? I use it a lot, but I never combine it unless the patient is in a really desperate situation. I always do it sequentially.
Yeah, because it's the steeper area which gets ablated if you do a topo-linking, which is also the thinner area. So would it really help in balancing the biomechanic forces?
Of course you're right, but I think this is my second concern. My first concern is to stop a disease called keratoconus. That's my first concern. My second concern is how to maximize vision. I maximize vision in most cases with scleral lenses, because they are far superior than any excimer laser. In a second step, I use the excimer laser, and the main reason for me not to do it in parallel is you have anything we do in biology follows a Gaussian curve, right? That's what we learned in medicine. So if you do cross-linking, most of your patients will behave the way you predicted. But you have two outliers. You have the ones that fail. We have failure and epi of cross-linking. What happens to those if you perform a simultaneous topo-guided PRK? You are in big trouble. And the others are the ones that show massive flattening. We've published on this, others too, flattening of 8, 9, 10, 11 diopters after standard cross-linking. So if I do a simultaneous topo-guided PRK, again, I'm in trouble. So I personally always wait half a year, I see where my patient is standing. And if the patient is improving, I wait up to 5 years in some cases, because I know I will do the surgery someday. So why not just wait, shift your volume towards a later point in time and make the patient happy.
Thank you.
So you will be doing the cross-linking first and then the PRK later?
Yes, and after 6 months I'll look at the file. So either I have these rare failures or extreme flattenings, then I have a different problem, or they are stable and I start discussing the PRK, or they improve and then I tell them, well, as long as you improve, we'll wait. Yeah.
One argument against that approach is that you're removing cross-linked strong cornea, and maybe the subsequent treatment will weaken it further. So maybe regularizing the cornea first and then subsequently cross-linking would be a better way
Yes,
to go.
again, there is pros and cons for both, but as I said, if I have a published failure rate in epi-off Dresden protocol cross-linking of 3 to 7%, this means 3 to 7 patients out of 100 will not respond to cross-linking, and you perform a PRK on them beforehand in a cornea that is biomechanically very, very special. I wouldn't want to do this. Yeah. And this risk for me is greater than the risk of ablating 40 or 50 microns out of the 300 that I have cross-linked. Yeah.
So if you're doing it later, would you follow the same protocol as what we do, like hyperopic ablation in the flatter area and myopic ablation?
We have studied the ablation behavior of excimer lasers after cross-linking, and we have published on this. On a Schwind platform, you need 11% more energy with each laser pulse to do what you do in a non-cross-link cornea. And so this was a directed research project with Schwind, and last year they implemented this into the global software of the Amaris laser. So now you have a checkbox that says patient has been cross-linked, and then the whole algorithm changes and you should be a little more precise. Yeah.
What are your views on LASIK extra, sir? Yeah.
I'm sorry,
Yeah.
I don't know whether...
Please turn. What are your views on LASIK extra? Do you think it's music or noise?
I think it's a lot of noise. Yeah, I don't believe in LASIK extra at all, and we have heard so many reasons why anybody has a hard time believing in it. The latest proof, if you want so, has been given by Brett Randleman from our lab at USC, who has measured with Giuliano Scarselli Brion microscopy in LASIK extra and couldn't find any difference between non-LASIK extra and LASIK. So absolutely no increase in biomechanics.
And it may also give a false sense of security and may make you take a wrong judgment at times.
Exactly,
So
and it gives us a false sense of security. And how many ectasias have we seen since we have Scheimpflug imaging diagnostics, a better concept of what's happening to ectasia? And as have so many others said, if you want to do a solid prospective study to show that LASIK extra is really worth it, with the current occurrence of ectasia, you need to treat tens of thousands of patients until you show that there is a benefit to it. Nobody has done this so far. Yeah. Thank you.
Thank you, sir. I think we can take more questions later. Thank you for
Thank
that great talk, and all of us will be waiting for the newer results and newer concepts next time you visit India.